constitutes for 50 to 60%. Arising from right, left, or common hepatic duct. And of course, and also 20 to 30% of the time, the cholangiocarcinoma arises from the distal common bile duct. In older studies, Klatskin's tumors have been misclassified as intrahepatic cholangiocarcinoma. And it is important, this distinction, because there is different histopathology, genetic alterations, and hence treatment changes between these two types. Just to overview, so intrahepatic cholangiocarcinoma constitutes for 10 to 20%, distal 20 to 30, and the rest is perihilar cholangiocarcinoma. Then as far as the growth pattern, so it can be a mass farming, as it describes, it presents as a mass lesion within the liver parenchyma. It can be intraductal polypoid, or it can be periductal infiltrative. These are the three types of intrahepatic cholangiocarcinoma. And extrahepatic cholangiocarcinoma, which is perihilar Klatskin's tumor, also can have any of these presentations. It can be intraductal, perihilar, or mass farming type. Coming to the risk factors, intrahepatic cholangiocarcinoma, obviously any hepatocyte injury related to whether viral infection, PSC, or metabolic associated syndrome. Whereas extrahepatic cholangiocarcinoma related to either parasitic infections, primary sclerosing cholangitis, or chronic inflammation can cause increased risk. And there are some precursors that develop into cholangiocarcinoma through multi-step carcinogenesis. These are similar to, you have to think in terms of pancreatic ducts, like IPMNs of the pancreatic duct or risk factor for pancreatic adenocarcinoma. Similarly, bile duct is equivalent to pancreatic duct. So intraductal papillary neoplasm of the bile duct, known as IPNB, any biliary epithelial neoplasia, mucinous cystic neoplasms, or intraductal tubulopapillary neoplasm. These are all precursors that can progress into cholangiocarcinoma. Let's take a look at a couple of examples of these precursor lesions. Here, there's in the left hepatic lobe, the biliary ducts are dilated. There is intraluminal polypoid, soft tissue. There is also biliary stent. Further down, we can see this polypoid tumor going into the common hepatic duct as well. I mean, imaging wise, it can look, we cannot distinguish from intraductal growth pattern of cholangiocarcinoma, but on pathology, this is intraductal papillary neoplasm of the bile duct, and eventually these can progress to invasive cholangiocarcinomas. Another example here on MR, this is a T2. We can see the right posterior hepatic duct is dilated with some heterogeneity within the duct that is showing some, and T1 pre-contrast, T1 on the post-contrast images, some enhancement. Again, on pathology, this turned out to be intraductal papillary mucinous neoplasm of the biliary duct. Now, moving on to the growth patterns. So mass farming is the most common growth pattern of intrahepatic cholangiocarcinoma. And it can be mass farming ductal or parenchymal, but the intrahepatic this is the most common type. Obviously, whenever there is mass farming intrahepatic cholangiocarcinoma, it needs to be differentiated from HCC combined, HCC intrahepatic cholangiocarcinoma, and as well as metastatic lesions. Periductal and intraductal variants can occur in intrahepatic, but are more common with extrahepatic types. And sometimes, of course, we can see mixed types as well with mass farming, but also a component of periductal infiltrative element as well. Typically, periductal infiltrative tumors have worse prognosis, whereas intraductal have the best prognosis. And moving into the histopathological classification of cholangiocarcinoma, there are two types, distinct types, large duct and small duct. And by the name itself, the small ducts, they arise from the small bile ducts distally. So on imaging wise, you'll see a mass forming lesion in the peripheral portion of the liver parenchyma. Whereas the large duct, they arise from second order biliary tracts, and typically these intraductal papillary biliary neoplasms, these are the risk factors for large duct type. And pathologically, they have mucin secreting glands and associated with KRAS and TP53 mutations and poor prognosis, whereas small duct type, typically they do not contain non-mucin secreting glands, and they have IDH1, IDH2, FGFR2 mutations and carry a slightly better prognosis compared to large duct type. Now, there are some distinct imaging features that can help to distinguish large from small duct and imaging as well. Typically, large duct type, these are large tumors, hypoenhancing. They're not well circumscribed, typically infiltrate to component associated with biliary dilation, lymphatic invasion. So we may see lymph nodes, portal vein thrombosis. They can have mass forming as well as periductal pattern of spread. Whereas small duct type of tumors are typically arterially hyperenhancing, at least rim hyperenhancement, targetoid, and they typically do not associated with biliary dilation or lymphadenopathy, and typical growth pattern is mass forming type. So we typically do not see periductal growth pattern with small duct type of cholangiocarcinoma. So to reiterate again, large duct type, so it presents with large intrahepatic mass with poorly defined margins, associated biliary dilation, can see lymphadenopathy, vascular invasion. There can be a mixed pattern with periductal infiltration. The mucin can be seen as in the form of hypodense areas on CT or T2 hyperintense areas within the mass. And of course, there can be intrahepatic metastatic lesions. Just to again reiterate the histopathological aspect, large duct type contains mucin-containing cells. There is high rate of desmoplastic stroma and frequent perineural invasion, whereas small duct type is non-mucin containing. And whereas with the small duct type, we'll see a well-defined mass, rim arterial phase hyperenhancement, so targeted features depending upon the amount of fibrosis. So let's take a look at some examples. So this is a biopsy-proven small duct type of intrahepatic cholangiocarcinoma. So obviously there is a mass forming type. So growth pattern is mass forming. We do not see any biliary dilation. This is a T2 weighted images, T2 intermediate signal intensity lesion, fairly well circumscribed. There is rim enhancement, arterial phase rim enhancement. Some degree of progressive enhancement is present. Obviously, there is some kind of desmoplastic stroma or necrosis in the central part of the tumor. And this is a biopsy-proven small duct type of cholangiocarcinoma. There is no associated lymphadenopathy. Whereas comparing to that case here, there is a large tumor. It has some arterial phase hyperenhancement, but we can see on the more delayed phase images, there is washout of this arterial phase rim and more central enhancement, indicative of some desmoplastic reaction in this tumor. There is some degree of biliary dilation is present here adjacent to this mass lesion. So this is a large tumor, associated biliary dilation, large desmoplastic area, indicative of a large duct type of intrahepatic cholangiocarcinoma. Then let's take a look at the growth pattern of intrahepatic cholangiocarcinoma. So we looked at the mass forming type, and then other two types are periductal. So where you can see a tumor presenting as bile duct wall thickening, biliary strictures, obviously enhancing soft tissue, and then intraductal polypoid where you see a polypoid lesion within the common hepatic duct. So here is a lesion within the left hepatic duct. We can see kind of soft tissue on the arterial and the portal venous phase. Same patient. We can see the soft tissue within the dilated biliary ducts. And this is a 10-minute delayed MR image. This is actually the tumor that is enhancing, not the the portal vein, and we can see kind of intraluminal polypid areas also demonstrating. So this is a classic appearance of a intraductal polypid cholangiocarcinoma with some degree of course, mass forming element is always there. That is kind of encircling the left portal vein here. Let's take a look at some other examples here. So this is a extrahepatic tumor. Obviously, we can see there is concentric wall thickening causing occlusion of the common bile duct, leading to some upstream dilation. Whereas this is a mass forming type of intrahepatic or central cholangiocarcinoma. Periductal infiltration is also there. This is classic example of a periductal type where this is the MR delayed image. You can see these biliary ducts are dilated. There is soft tissue in the form of thickened biliary duct wall that is kind of enhancing. So this is a periductal infiltrative type of cholangiocarcinoma. This is an example of a intraluminal polypid mass. It's kind of less common presentation, but when present, this carries good prognosis. Of course, there can be a combined type. So it is an example. So there is a mass here on the arterial face. This is a venous phase that is contiguously extending to the hepatic hilum. We can see this wall thickening and enhancement of the cystic duct and as well as the common hepatic duct, indicative of a combined growth pattern, mass forming and as well as periductal type of growth pattern. Same patient here, just to show on the coronal images here again, this is the mass that contiguously extends and causes this thickening and enhancement of the common hepatic duct, cystic duct wall, indicative of both mass forming and as well as periductal type of growth pattern. So for intrahepatic cholangiocarcinoma, obviously on imaging, it can be challenging to differentiate from metastasis if it's only one lesion, particularly small duct type lesions, whereas 1 to 2 centimeter mass, metastasis can have similar appearance. And obviously, there is also a newer entity called combined HCC cholangiocarcinoma, which is kind of LRM category in LIRADS. It can be imaging wise, it can be difficult to differentiate. Of course, there are other, sometimes sclerosing hemangioma or atypical HCC can also have similar appearance. So let's take a look at this example. This is a patient with cirrhosis presenting with a large mass lesion. There is arterial phase hyperenhancement, and this is a rim enhancement. So obviously, this would be a LRM category. And then we can see washout of that rim on portal venous and delayed phase images, and then progressive enhancement of the central portion, as we can see here. So this would be considered LRM based on the LIRADS because it has a rim arterial phase hyperenhancement that is progressively enhancing. So, imaging wise, this can be, cholangiocarcinoma. And biphenotypic tumor, HCC cholangio can also have this kind of appearance. And this one turned out to be a cholangiocarcinoma. And to make our, differential, there is also a sclerosing variant of HCC that can have similar appearance. So sometimes on imaging, it can be really difficult to differentiate from this combined HCC and cholangio tumor, particularly if the patient has cirrhosis. And it's not just that these are just academic purposes. There are, studies that have proven that, some imaging features have, good prognosis, whereas other imaging features are bad prognosis. So less delayed enhancement and arterial hypervascularity are associated with good outcomes. Delayed enhancement indicates more fibrous struma. So delayed enhancement of more than 2/3 of the tumor is associated with shorter survival. There's more aggressive perineural invasion. Whereas if it is less than 2/3 of the tumor, that indicates less fibrous stroma on histology and longer survival. And as well as if there is arterial hypervascularity, typically a feature of small duct type of cholangiocarcinoma. And these tumors typically do have good prognosis compared to large duct type. And it has proven in multiple studies. So there is arterial hypervascularity associated with less metastatic lymph nodal disease, less invasion of the portal vein, and as well as intrahepatic mets, less fibrous stroma, longer disease-free survival, and a higher 5-year survival rate. Now, moving on to staging. Obviously, we'll start with regional lymph nodes. For right intrahepatic cholangiocarcinoma, the regional lymph nodes are hilar. Any nodes adjacent to the hepatic arteries, portal vein, and cystic duct. Periduodenal, peripancreatic lymph nodes are also considered regional for right hepatic cholangiocarcinoma. And for the left hepatic cholangiocarcinoma, hilar and gastrohepatic nodes are considered regional lymph nodes. So when regional lymph nodes are present, that doesn't preclude from surgical resection. And obviously, the most common sites for metastasis are other than the regional nodes, satellite lesions within the liver, lungs, peritoneum, bones, and brain. This is the assessment from database. Treatment algorithm. These are the various treatments that are available to these patients. Resectable is typically it's presented very delayed because of asymptomatic nature until unless if the tumor is causing obstruction to the bile duct. If it's mass forming type, particularly they present late, and hence resection may not be possible in all patients. It's possible only in 20 to 30% of patients. For unresectable patients or metastatic patients, there are systemic therapy options that includes either chemotherapy, combination with immunotherapy, and some targeted therapies that are available. So surgical resection is the only curative option, but only few patients are eligible at diagnosis. Liver transplantation is available in certain selected cases, and it is accepted in the United States. And first-line systemic therapy now with the advances with immunotherapeutic agents, typically in US, is given with gemcitabine, cisplatin, and durvalumab. And there are emerging role of immunotherapy in selected patients. So let's take a look at the surgical options. Resection criteria depends on the future liver remnant. With intact, of course, hepatic arterial, portal venous, hepatic venous, and biliary drainage, right? Obviously, it's excluded in patients with distant metastasis, or bilobar tumor, or non-regional nodes. If the patient is surgical candidate, then median overall survival is 50 months, and relapse rate can be seen in up to 60% of the patients. Just to go over some liver anatomy, without going into too much details, in the superior segments, you have segment 7, 8, 4A, and 2 divided by right, middle, and left hepatic vein. And these are the middle segments that are of the main portal vein. And inferiorly, you have 3, 4B, 5, and 6. And when we talk about the liver resection, hepatectomy is, whether you do the right hepatectomy, segments 5 to 8, or left hepatectomy, segments 2 to 4, including cardiac lobe segment 1, or it can be just resection of one segment, or resection of two vertical segments, right posterior, right anterior, left medial, left lateral. And sometimes one can do the extended hepatectomy. But the key thing is, for intrahepatic cholangiocarcinoma, the resection criteria depends on future liver remnant. So what is adequate future liver remnant? For normal healthy liver without any background liver injury, 20% of the remnant liver is adequate for successful recovery. But if the patient has received some kind of chemotherapy of at least 12 weeks, then ideally we need to have at least 30% of the liver remnant should be left after we resect the tumor. Whereas when extensively treated, meaning chemotherapy that has been given for 6 months, or if there is a child pug, a cirrhotic liver, then you would want it to have at least 40% of the future liver remnant. But there are also some other techniques that can be used to improve the future liver remnant volume by, you know, embolizing the contralateral portal vein. Suppose if you are resecting the right lobe and we want to have hypertrophy of the left lobe, we can do the right portal vein embolization so that left lobe can hypertrophy. Or if there is some biliary dilation of the left lobe and maybe drainage of the biliary system from the left lobe to hope for, hypertrophy of the left lobe to reach these future liver remnant volumes. So obviously, unresectability, when you cannot leave that, 20 to 40% of the future liver remnant without disease, that is unresectable. Meaning, suppose if there is involvement of both sides, right and left hepatic duct, that is a contraindication. Bilateral involvement of the portal or arterial branches, involvement of the main portal vein, or atrophy of the hepatic lobe with involvement of the contralateral. So these are all kind of traditionally we used to use, but now the thinking is all about the future liver remnant. And the degree for extrahepatic cholangiocarcinoma from the common hepatic duct or distal cholangiocarcinoma, we use typical that of the pancreatic adenocarcinoma type of assessment for resection. So if there is abutment with the celiac artery, common hepatic artery, if it involves less than 50% of the vessel circumference abutment, so in those cases, we can give chemotherapy and restage to see if there is adequate margin. But if there is a vascular invasion, meaning is a complete encasement 360 degrees, or if there is any, occlusion, contour deformity, or tumor thrombosis, that precludes, surgical resection for extrahepatic cholangiocarcinoma. Now, moving on to the palliative non-surgical options. So there are various systemic therapies that are available. And that will touch base a little later. And also in some patients with oligometastatic, there is ablative radio options are available that can be either, Y90 embolization, microwave ablation, or external beam radiation therapy, or TACE therapies that are also available for kind of achieving local control. So let's go on to the genetic heterogeneity and some actionable mutations in intrahepatic cholangiocarcinoma. These are found in up to 40 to 50% of cases. It provides opportunities for targeted therapies. These are the common genetic alterations in intrahepatic cholangiocarcinoma: IDH1 or 2, FGFR2 fusions, KRAS mutations, HR2 amplifications. These are more common with gallbladder cancer. And there are targeted therapies for these mutations. For example, the FGFR inhibitors, these are the FDA-approved agents that are available to treat these patients as a second line after failed initial treatment with gemcitabine and durvalumab, IDH1 inhibitors, and various other therapeutic options. So IDH1 and IDH2 mutations, these occur in about 10 to 20% of intrahepatic cholangiocarcinoma cases. Commonly seen in small duct type of cholangiocarcinoma. And then often small duct, more frequent in Western countries. And similar overall survived compared to wall type after surgery. And FGFR is the second most common mutation, seen up to 15% of the cases. And it is associated with better prognosis and younger age. And we have seen some excellent response when this mutation is present with FGFR2 inhibitors. And these are the two agents that are approved. One is reversible FGFR inhibitor, other one is irreversible. But unfortunately, some patients develop resistance within 1 year after starting these drugs. There can be some common adverse events such as hyperphagocytemia associated with these drugs. And KRAS mutations, these are tend to be more aggressive type of tumors. So when we look at the systemic chemotherapeutic options, we look at chemotherapy traditionally. with GEM and immunotherapeutic agents. And now, there are a lot of targeted therapeutic agents are available. So on imaging wise, if you have a cholangiocarcinoma treated with the FGFR inhibitor, typically you would expect the size to decrease, vascularity go down, and some patients develop calcifications within the tumor. That is actually a treatment response. Here is one example. So before treatment, this is a large infiltrative tumor. There were also multiple associated satellite metastatic lesions within the liver parenchyma. This is at the baseline, kind of venous delayed phase images. And after FGFR therapy, this patient progressed on traditional chemotherapy and FGFR two inhibitor therapy. You can see kind of necrosis, lack of enhancement, and development of calcification. So this is kind of considered excellent response to FGFR2 inhibitor therapy. Similarly, IDH1 therapeutic agents, on imaging wise after therapy, we can see kind of development of necrosis. So intrahepatic cholangiocarcinoma is incidental in 20 to 25% of cases, and incidence is rising, unfortunately. Delayed diagnosis due to asymptomatic nature, and of course, no screening markers are available. Two subtypes, large duct and small duct, they differ in pathobiology and genetics and immunohistochemistry. Management is slightly different, and of course, with a distinct prognosis. Imaging biomarkers useful for differentiating subtypes based on whether well-circumscribed tumor, arterial phase hyperenhancement, at least REAM targeted appearance is seen with small duct, whereas large infiltrative tumors associated with biliary ductal dilation, lot of fibrosis on delayed phase is seen with large duct type. And, on imaging, one can try to, differentiate small duct from large duct types. And, we know this is a very heterogeneous tumor. Heterogeneity is seen both in genetics and imaging appearance. There are actionable mutations in up to 40 to 50% of patients that allow for targeted therapies. IDH1, 2, and FGFR are the most frequent actionable mutations with available therapeutic agents that can target. And tumor microenvironment influences the prognosis. There are several ongoing trials continue to expand treatment options for these cholangiocarcinoma patients. With that, thank you so much, and I will take any questions.
Thank you very much, Dr. Surbi, for the excellent and comprehensive lecture. We will now move on to the Q&A session. Please feel free to type the question in the Q&A box. Okay. Okay, Dr. Surbi, I have two questions. In your experience, sometimes I think I find it difficult to differentiate liver metastasis from adenocarcinoma from mass-forming cholangiocarcinoma. Do you have any tips and tricks for differentiating these two? Yes.
Yeah, I agree. Definitely. Mass farming type of cholangiocarcinoma versus metastasis, at least on imaging, they have similar pattern, right? In terms of, hypovascular, progressive enhancement on delayed phase images, diffusion restriction, T2 signal intensity. It's just the, presentation, it's just the solitary versus multiple. Do we, patient has any history of primary malignancy, or do we see on most of the times, primary is within the abdomen and pelvis. So do we see any colorectal mass lesion, or in female patients, any ovarian lesion, or a pancreatic mass? So I think it's more than just a pure imaging appearance. I think it's an overall presentation. And then multiplicity sometimes can help, although, cholangiocarcinoma can have intrahepatic satellite lesions, making it difficult. But if there is presence of segmental biliary dilation, that can favor cholangiocarcinoma or metastatic lesions. And I think biliary dilation, when it present, I think can help towards favoring cholangiocarcinoma over metastatic lesions.
Okay, thank you so much for the answer. Okay, we now have three questions in the Q&A. Okay, the first one. For resectability, can you please clarify more how to check vascular involvement and which vessels? Thank you.
So resectability, so traditionally, there is a difference between intrahepatic cholangiocarcinoma from extrahepatic common bile duct. So for intrahepatic cholangiocarcinoma, it's all about future liver remnant. Without, of course, that remnant should be free of disease and be able to have arterial supply, portal venous, hepatic venous drainage, and bile duct that is not involved from tumor. So, for example, if you have a right hepatic lobe mass lesion that is reaching to the level of the hepatic hilum, and if it is not extending to the left biliary duct, or left portal vein is fine, left hepatic artery is without disease, that means you can do the right hepatectomy and leave the left lobe of the liver. On volume measurements, if it comes out to be future liver remnant is 20%, then of course we can proceed with the surgery, and vice versa. For example, left hepatic lobe lesion, similarly, if you have right portal vein, right hepatic artery, right bile duct is free of disease. Whereas if there is a tumor in the right lobe, but it also causing narrowing of the left portal vein, that means we cannot do the right hepatectomy because left portal vein is also compromised. And same with the right lobe lesion that goes to the central hilum and involves the left biliary duct, then we will not be able to do. Although sometimes you can also do extended right hepatectomy and see if you can, extend the biliary duct margin to have a R0 resection. So that's for the intrahepatic cholangiocarcinoma. It's about, whether are we able to leave the enough liver parenchyma without, have with normal arterial, portal venous, hepatic venous, and biliary drainage. Whereas extrahepatic cholangiocarcinoma for distal CBD or mid CBD, we look at the adjacent vascular involvement, whether fat planes with the main portal vein, common hepatic artery. If it's typically if it's a abutment with the main portal vein is not an issue. But if there is a abutment with the common hepatic artery, if it's less than 180 degrees, we typically give chemotherapy and then restage. But if it's more than 180 degrees, 360 degrees circumferential involvement, then that would be a contraindication for surgical resection.
Thank you so much for the answer. Okay, we have more questions here.
Yeah, I can. Yeah, so there is only surgery the way to differentiate IPMN from intraductal cholangio. I mean, it can be differentiated on biopsy. Sometimes they do ERCP with cholangioscope. They can go sample that polypid area and be able to tell. Sometimes, but it can also be limited on histology. Sometimes pathology can say we see atypical cells. We cannot really exclude invasive element. In those cases, surgical resection is ideal. And anyway, these are pre-malignant lesions, intraductal, biliary neoplasms. So you would want to resect them anyway if the resection is possible. So yes, it can be diagnosed on biopsy, but yes, sometimes it can be difficult to diagnose on biopsy and hence requires full surgical resection. And there is another question on the chat about what is chemoembolization role and what material we use. Typically, here, we are using Y90. We are not doing plain chemoembolization TACE. Unlike for hepatocellular carcinoma, we still do TACE, but with the cholangiocarcinoma, the only transarterial therapy that we are doing in selective patients is Y90 embolization.
Okay, the next one. How often does HCC infiltrate the bile ducts? How do we tell the difference between HCC infiltrating the bile ducts with mass-forming cholangiocarcinoma?
Excellent question. I think the HCC infiltrating bile duct is very less common. It's 4 to 10% of the time. So, but even more less, at least on my experience. compared to cholangiocarcinoma invading the bile ducts. That's one thing. And second thing, often I see HCC, if it's invading the bile ducts, I would expect also to see a significant vascular invasion. So if there is vascular invasion, and then if there is a tumor thrombosis enhancing during arterial phase, that is a clue towards HCC over cholangiocarcinoma. And those are the pointers towards. And of course, you could use serum tumor markers. If the alpha fetoprotein is high compared to CA 99, that could give pointer towards hepatocellular carcinoma over cholangiocarcinoma. Yeah.
Are there any reason to do gadoxetate disodium MRI in suspected ICC?
So suspected. So we do use gadexetate, kind of more of a follow-up and staging before resection, just to identify if there are any satellite lesions that we need to go after. But for suspected intrahepatic cholangiocarcinoma, uh, I do not see a role for definitive diagnosis, because sometimes the gadexetate can complicate appearance of other lesions. For example, hemangioma, if there is arterial phase is limited, then on the hepatobiliary phase, cholangiocarcinoma is hypointense. Similarly, any other non-hepatocyte containing lesion would be hypointense, so it can be tricky. So we still use we don't use gadexetate for suspected, but yes, gadexetate has a role in kind of deciding and surgical resectability, and really trying to look for satellite lesions in the other lobe that we are planning on leaving.
Thank you. For case just bile duct dilatation with subtle intraductal lesion, do you have any modality to choose in diagnostic or period to follow up?
Oh, yeah, MRI with MRCP is preferred over CT. With intraductal lesion, obviously, we would be able to assess better. And for the period for follow-up, so sometimes, see, if we see already an intraductal lesion, whether it is subtle, or if we see something in the bile duct that is enhancing, or if there is a wall thickening, uh, then we tend to be more aggressive in recommending ERCP with SPY-scope, so that they can go look at that area and then biopsy. But if we see just a bile duct dilation without associated any intraductal lesion or wall thickening, just dilation, sometimes we do see. And in those cases, if at all, if they can't do ERCP or SPY-scope, or for other factors, at least 6 months follow-up with MRCP. First follow-up will be in 6 months, looking at the duct status, and then go from there. If there is any change in morphology, then the patients can go to ERCP or SPY-scope, or if there is no change, stability, then another 6 months. But I don't know of any particular guideline that is available. Yeah, I need to look into it as well. So it's kind of more anecdotal. It's based on the discussion in the multidisciplinary tumor board conference.
How to differentiate IgG4 cholangiopathy from periductal cholangiocarcinoma?
Oh, okay. That's an excellent question. There is no no clear-cut answer. Only thing is IgG4 cholangiopathy. If it's associated with autoimmune pancreatitis, of course, then you will see pancreatic manifestations. If there is mediastinal lymphadenopathy, retroperitoneal lymphadenopathy, or renal involvement. So if it is systemic, yes, if there are other organs are involved, that is a clue towards that it's probably not cholangio and some IgG4 related disease. But if it sometimes I've seen cases of just biliary involvement. In these cases, it is difficult. And in fact, we published paper on mimics of cholangiocarcinoma, and that is one of them. And it can be tricky if it's just isolated biliary involvement. But if the other organs are involved, I think that helps.
Thank you so much, Dr. Surabhi.
No
So
problem.
that's the end of our session today. On behalf of AREP, I'd like to sincerely thank Dr. Surabhi for sharing valuable knowledge and insights with us. I would also like to thank the audience for your participation. We hope you found the session useful. Please stay tuned for our upcoming webinars. And now let's get back to Dr. Turpaning. Thank you.
I thank you so much. I really enjoyed and such a and I enjoyed the questions too. Such an interactive session, as always. It's a great session. Thank you again.
Thank you,
Thank
Dr.
you.
Surabi, and thank you, Dr. Sacha. You both can leave if you want to, because I'm gonna do a housekeeping.
Thank you so much, Nat. See you later. Bye.
See you, see you. Thank you, thank you.
Thank
Can I
you so
share my?
much.
Yes, thank you. Can I share my screen now? Yes, I'm gonna share it.
Yes, you are host now, and you can share the screen.
Yes, do you see my screen at all? No?
I see
You
the
only see
screen.
black screen.
Okay, let me do this because it doesn't. Okay, let me do the screen too. No, it's blank, right?
Yeah, black screen.
Okay. Okay, I'm gonna do a verbal announcement here. So our next webinar, we're done with body and MSK session this year. So next two session will be woman imaging. The first one will be introduction to breast MRI, which gonna held on the first Sunday of September, which is the 7th. So our speaker will be Boven No from Wake Forest University, and our moderator will be Dr. Pema from Bhutan. Okay, please stay tuned, and we will send out the flyer and the link to you all. So it's going to be introduction to breast MRI. Okay, for the beginner. I think we're all done for today, and thank you everyone for joining us. And stay tuned with your email so you see the news from us, because it's almost the end of the year. We're almost done. We're done in October. Okay, all right. See you all.
Thank you, Dr. Nat. And see you on next webinar.